Some people have great success with it. Some people don't find the braces are quite as helpful. It's always certainly something to try and then see if it's effective or not for you. And then lastly, addressing your work and sporting activities. So by reviewing your sports equipment, such as the sizing of your racket, of your grip, and the handle. Nowadays, rackets are definitely changing, and there are sometimes the modifications that you can make to make sure that your equipment is right for your body. String tension and type are very important. Again, nowadays, there's lots of different types of string out there when it comes to tennis rackets, and typically more of a natural gut. The only reason I know this is because my husband owns a tennis store, so he was informing me on some of more of the what he sees commonly in a tennis store, but the natural gut string will typically be, and a softer string is what you would want in your tennis racket if you had these problems. And then obviously technique. So sometimes you have to get to the source of the problem and make those corrections in your technique. The golfer's elbow, basically same thing as the tennis elbow, except now we're working on the medial side of our forearm. And that's going to be degeneration now of our flexor muscles, so on the underside of your arm, okay? And their site of origin or insertion is going to be on the medial epicondyle instead of the lateral epicondyle. Mechanism of injury is very similar, often the result of repetitive overload from your recreational activities or occupation, things such as pitching, golf, hammering, or anything that involves you repetitively turning your hand over this direction is what would affect the flexor muscles. Again, it may be sudden or it may be gradual. If you had a really big blow, a big trauma hammering something, it could be a one-time, initial injury, but more typically it's that kind of gradual, repetitive motion that's going to, over time, lead to the wear. Signs and symptoms of golfer's elbow would be, again, the history of the overload to those wrist and flexors and forearm pronators. You might feel tenderness if you try to palpate yourself over that proximal end of muscles at the medial epicondyle. You'll have pain with resisted flexion, bringing the wrist towards you and trying to push away, give yourself resistance, may be irritating, and pain with that resisted pronation. So if you're trying to turn the hand down, and if you get resistance there, that could be irritating. Your wrist extension, stretching the hand, and stretching those forearm muscles may be limited and it may be painful. But again, your elbow is good. You have full range of motion, and it's usually pretty painless as far as the elbow motion. And then wrist extension is pain-free. Again, this is more for diagnostic purposes and for properly getting diagnosed. And this would be something that if you started to see some of these signs and symptoms, you might want to try to go to your physician and get properly diagnosed and then treated with therapy. Your treatment would be to reduce inflammation, soft tissue massage, progressive exercises for flexibility and strengthening of the wrist flexors and forearm pronators. One of the common things is that people will come to therapy and they'll show me what they're doing at home, which is great. I'm very encouraged that you're trying to do an exercise at home, but what you need to make sure you're doing is utilizing the right technique and really getting the correct muscles. So if you're not stretching your wrist flexors and your forearm pronators, then you really haven't been addressing the right muscles. And again, that would be something that you would want to make sure that you knew you were doing appropriately. Golfer's elbow, you can try using the counterforce brace. Again, that's meant to minimize the tension force between the tendon and epicondyle, and then address your work and sports activities. So there's a series of things that need to be done to properly treat this condition so that you can fully resolve it and not have issues chronically. Everyone doing okay still? Okay. These are just a couple of very simple images. If you Google any type of image, you'll be able to see for yourself what tennis elbow looks like. You can see on the right side, or the left side as you're looking at it, there's an actual tear in the tendon. Remember, your tendon connects the muscle to the bone, and you get a tear. Remember, those tears can be graded, different levels of severity, and dependent on how many fibers are torn, it would depend on the extent of the injury. And then on the picture on the right is just a brief picture of the medial epicondylitis or the golfer's elbow. So your pain would be more on the medial part of your arm. Okay, so lastly, bursitis, okay, which is something that a lot of people are diagnosed with, and I get the question very, very commonly in therapy is, what is bursitis? Teach me what bursitis is, because I've been diagnosed and I don't know what it is. So it's an inflammation of the bursa, and just like our tendons, okay, which we have many different tendons all over the body, we have bursa sacs all over our body. And commonly at every single joint, you're going to have a bursa sac. And basically, it's meant to help lubricate the joint. It controls the friction between the tendons and the bones. And they have normally a natural amount of fluid in them to help with that kind of lubrication and to decrease that friction. Commonly, people will get, again, kind of in regards to the shoulder, they could get a subacromial bursitis, okay, and we'll talk about that. But a lot of times people also will get a bursitis in the hip. Sometimes you can get a bursitis in the knee. Again, the shoulder is very common, so it can occur anywhere that you have a bursa sac. All right? The mechanism of injury, it frequently occurs as the result of direct or repetitive trauma. Okay? Now, you might think that sounds familiar because that's very similar to a tendonitis. But typically, tendonitis and bursitis go hand in hand. If you have a tendonitis, you're probably going to have a bursitis as well, because that tendon has gotten bigger and now it's rubbing on the bursa sac and kind of creating fluid enlargement in that sac. So the soft tissue injuries are very rarely isolated, and that's why they can be difficult to both diagnose and treat. And the good news is the treatment is similar whether you have a tendonitis or a bursitis or the epicondylitis. And that's why I'm talking about this, because treatment-wise, we're still going to address those symptoms of inflammation, pain, loss of range of motion, loss of strength, loss of function, whether it's the bursa that's inflamed or the tendon that's inflamed. Okay, so typically the bursitis is secondary to a tendonitis, meaning it's just as a result of. Your signs and symptoms of bursitis would be that you'd have a rapid onset of limitation of movement. Okay? Now, hip bursitis, again, that's a very, very common one that's treated and that we get sent for a patient, treating a patient in therapy. And typically it's very painful and it's come on suddenly. Okay? They may have had a previous history of tendonitis, which again, if that tendonitis has not fully been resolved, you're set up for that chronic stage. And then several movements would be painful, okay? Unlike for a rotator cuff injury, when really only you have specific movements of that abduction and that flexion, now if I try reaching behind my back, if I try moving my arm, I can really feel it and it's not so isolated. So that's typically more of a bursitis. It's not so localized and so pinpoint specific. And then definitely the big one is that you have pain at night and you'd have sleep disturbances due to inflammation. A lot of times in the hip, you're unable to lay on the side. In the shoulder, you're unable to lay on the side. And a lot of times that's just because you have so much inflammation now in that bursa sac that that friction of laying on the spot really increases your pain. So the pain at night is a big one for bursitis. Treatment-wise, these injuries respond favorably to ice, anti-inflammatory medications, and protective padding. Sometimes physicians may even need to aspirate the fluid if it's not reabsorbing. You can get a bursitis that's in your elbow, kind of right at the end, and they call it a student's elbow, because when students study, a lot of times just the repetitive trauma of putting pressure on their elbow causes that bursitis, and a lot of times it looks like a big goose egg there. But you need to, sometimes people will actually wear a protective elbow pad or something to basically eliminate that friction. And aspiration can be helpful because, again, by getting that fluid out, you're reducing the inflammation and returning the bursa sac back to its normal size. We can try ultrasound. That's an intervention in therapy that is helpful. And again, we would use a pulsed ultrasound. So that would be settings that a therapist would know to do for you. We try to eliminate the cause for impingement, okay, so that kind of that pinching of the bursa sac. We would try to eliminate those causes, establish normal range of motion, strengthen the shoulder and scapular musculature, and then progressively return to activity. So again, similar guidelines to what we were treating the other common soft tissue injuries with. Here's a quick picture of a bursa sac. Okay, if you see the picture of the shoulder, you can see that subacromial bursa and the subdeltoid bursa. Those are the two blue images on the top image. Okay, so you can see how they just are really lying there in the shoulder, and they're meant to really help lubricate and protect. You can see how the deltoid muscle is overlaying that bursa sac on the side. And again, if you have tightness or loss of motion, you're going to get a shearing, and that can cause that sac to fill up with more fluid. Okay, and then the bottom picture just shows how an enlarged bursa can cause impingement as you're trying to raise your arm. So now you have a structure that's larger than it should be, and that's affecting your movement as you're trying to raise the arm. So we need to try to address that so it doesn't get any worse. And I guess that's it. So what I will do now is open the discussion up here for any questions you may have, and we'll go from there. Yes, ma'am. Okay. Okay, yep. So in regards to your first question, it's an excellent question. And atrophy typically occurs in the muscle belly itself. So your muscles are made up of many different fibers. And what happens is you actually lose the girth and the sheer size of the muscle. So you can, in fact, restore that muscle size, and you can actually get that muscle to hypertrophy, which would mean to enlarge it. And that can occur through proper strengthening and resistance exercises. Typically, the tendons themselves will not atrophy. They will usually tighten, and as I was discussing before, they can become more fibrotic, so they will get thickened or they'll get roughened. Sometimes the fibers will be torn, but the tendons themselves usually don't shrink too much. It's really going to be the muscle, and that's why sometimes if atrophy is really known as, if you don't use it, you lose it. So if you've ever stopped using a muscle, you'll visibly see that the muscle itself shrinks. And so that part can be reversed, and it needs to be reversed in order to maintain your symmetry. As far as the bursa removal, obviously as a physical therapist, I don't perform that intervention. But sometimes people will end up having a bursa removed if the physician has felt that it has been, either a recurring problem for a person that they really just need to take out the structure and that they're better off not having it in there to constantly keep refilling up with fluid. A lot of that, and I have seen several people that have had the bursa removed, and then basically it just opens up the space. So again, that would be something, if I go back kind of to this picture, you could see if you didn't have that bursa sac in this bottom picture there, if that was constantly inflamed, if you didn't have that there, the idea would be that you'd have more space there, so you wouldn't be creating the impingement that way. But bursa sac sometimes, again, if it's a chronic condition and it occurs over and over with time, sometimes you do need to just remove it, and then that would be obviously the treatment to not have that fill back up with fluid. Is that okay? I think I saw a question over here. Yes. Mm-hmm. For physical therapy? So the thing with physical therapy is we do accept insurance. And if you would like your insurance to be billed, then yes, you need a physician's referral. So that's in both insurance guideline and a legal law down here. Now, we can treat in my clinic. I could treat you without a physician's referral for up to 25 days. If you did not get, and that would be on a self-pay basis. If you did not get better within 25 days and you felt that you needed to be coming longer, then you would need to be under the care of a physician so that he was aware of the situation and that you got maybe more further diagnostic testing. Or by that point, if I haven't gotten you better within that amount of time, then there's a good chance that you would need some further diagnostic workup, an X-ray, an MRI, maybe an injection or something like that. But typically, it's really an insurance limitation that if you would like to have your insurance be billed, then you need the physician's referral. Now, I always think it's a good idea that, again, if you have a well-established physician, that you see your physician and you have the discussion with them whether he thinks you would be appropriate for physical therapy with the diagnosis that you've been given. And hopefully, it's sometimes physicians are very well informed about what therapy can do, and sometimes physicians aren't quite that informed. So sometimes if you ask or you would request a referral for rehabilitation, your doctor could just write you a prescription off of your own request of going to him for that. But typically out here, if you had more of a musculoskeletal or neuromuscular injury, you could come in and I could evaluate you to see if you were appropriate for therapy. Now, if you weren't and it was a condition that was out of my scope of treatment, I would refer you to the appropriate provider before continuing to treat you. So that's typically how that works. And as a doctor of physical therapy, that's one of the big things is that we're educated in how to evaluate, treat, determine what's in our scope of practice for treatment, which would be any musculoskeletal and neuromuscular injuries. And if it's outside of that, then we know how to refer you to the appropriate provider. Yes, ma'am. Yes, we can use prescriptions from out of state for up to 30 days. It is a Florida law that after 30 days, if you were to continue treatment, then you would need to have a Florida physician follow you and sign off on your basically plan of care. But we could initiate treatment. All you would have to do would be bring your out-of-state prescription to our therapy clinic. We would set you up for an evaluation and we would work off of that. And I do send my evaluations to your out-of-state providers so that they know and they're in the loop as far as what is happening. But if you were to be treated for longer than 30 days, it's the Florida law to have an in-state physician follow you. Yes, ma'am. Did it fully resolve? Now, I have heard stories of that, and people have said it's taken up to a year for them of not doing anything. And that is, like we said, you went through the natural stages of healing then, which was good, and your body responded. And like we said, these conditions are fully reversible, which occurred. The problem is if you didn't want to give up your activity for a full year or a couple years, that's the hard part. The other thing is sometimes when you stop those activities for up to a year, that's what leads to some of the weakness of the forearm muscles and kind of that lack of range of motion. So that's great if that fully resolved, but sometimes the therapeutic interventions can help speed along that process. So, and hopefully it won't come back. Yes, sir. So sciatica deals with your nerve, and so that's kind of a whole different injury. That's not necessarily a soft tissue injury anymore. It's dealing with the actual irritation of a nerve. So like some of these soft tissue injuries, you go through a period of inflammation with sciatica. We treat sciatica very commonly in physical therapy, and again, there are some very good things for restoring your range of motion and strength that are helpful in fully resolving that. But it is different because you're dealing with a nerve inflammation instead of the inflammation of an inert structure like the bursa sac or the ligament or tendon. No, it's not obvious. There are definitely some different diagnostic tests that are help to guide, the diagnosis. But typically, sciatica, because it's a nerve, that's going to be more burning type of pain, referred pain, really kind of tingling, numbness, nerve type of pain versus, again, a achy pain, a repetitive type of pain, or induced with resistance. It doesn't matter if your muscles are resisted, whether that won't reproduce the pain when it comes to the sciatica. Sometimes if your muscles are tight around the nerve, then you can get a lot of times of a bursitis secondary, again, to the sciatica. Bursitis is really a lot of times a secondary problem. So you may have the sciatica as your initial problem with a secondary bursitis. But that's something that is definitely treatable too. Yes, ma'am? Mm-hmm. Mm-hmm. Well, you have a couple of other bursa sacs surrounding the shoulder too, not in that immediate area where you would have one removed, but there wouldn't necessarily be anything else there to replace the bursa sac. You'll get some natural scarring that occurs anytime you have removal of something, so there might be some scar tissue or a little bit of, that would be kind of residual from the surgery, but there wouldn't be there wouldn't be anything else to really replace that. You have the cartilage in your shoulder within the joint itself that will help protect the joint, but between, the structures there, you really wouldn't have anything else, just the other remaining bursa sacs. And again, you have a couple in the shoulder. You can see two up there, and that's, that would be just something that then in your body you would not regenerate a new bursa sac once it's removed. Yes. Mm-hmm. Yes, so swimming is very good for soft tissue injuries because it's low impact and it can be the water is a good medium to do exercises in. So swimming is very good. When you're actually doing swimming strokes, like the front crawl, or if you're swimming laps, sometimes you have to be a little bit careful if you have a tendonitis or a bursitis in the shoulder, because that over-the-head motion with the resistance of the water could be an irritating factor if that's the type of tendonitis you're dealing with. But if that's not directly stressing the tendons of the muscles involved, then you can use the swimming as an appropriate way to start to basically regain that motion and strength. A lot of times doing stretches in the water is a little more tolerable because you don't feel the pain quite as much. Again, the water helps to kind of ease the pain symptoms, and it actually allows you to move into positions you otherwise might be avoiding. But it really kind of depends on, what you're using the swimming for. Did I answer that okay, or did you have more specific questions? Any other questions from anyone at all?